Thank you, Elizabeth. I appreciate the introduction, and I want to thank everybody who made it here today. I'm hoping you'll get a clear understanding of what we've been doing and the history of the work that we've been doing. I'd like to take you on something of a journey as we talk about the research studies that we've been doing, really starting back in 2001. So it's been quite a long time. But first, I want to begin with some general facts about mental illness, because the issues that surround the diagnosis and treatment of mental illness are too large to ignore. In any given year, 1 in 5 U.S. Adults experience some form of mental illness. And 1 in 25 adults in the United States experience some serious mental illness. The cost to the United States is about $193 billion in lost earnings. And half of all chronic mental illness begins by the age of 14. So early recognition and diagnosis, particularly of the most serious forms of mental illness, is obviously a critical issue, and it's one that we're most interested in. So let's begin with some facts about mental illness. Just so you know, I've pretty much devoted the last 15 years of my professional life to the study and treatment of mental illness, and in the last 15 years, in a search for the causes and for better treatments of juvenile bipolar disorder. So, a large part of the problem that we encounter in the field of psychiatry lies with the fact that, unlike with any physical disease or injury, the diagnosis of mental illness remains rather elusive. And here in the Bruce Museum, you'll find a section devoted to artifacts from the history of medicine. Sorry. And in those artifacts, you'll see basically how medicine has proceeded, basically looking more at over the years at the underlying cause, the pathophysiology of physical illness. In psychiatry, on the other hand, when the DSM-3, which was the second version basically of the diagnostic manual in psychiatry, basically diagnoses are formed based on expert consensus. So essentially, it is a group of expert individuals who presumably are expert in particular areas of various conditions, come up with a diagnosis that is believed to be reliable, so that one psychiatrist in Boston can essentially diagnose the same condition as a psychiatrist in San Francisco, let's say, but they're not based on any. There's not based on any real underlying pathophysiology, meaning a physical illness that can explain the behavior, as most illnesses are in medicine. So when the DSM-5, which is the latest iteration of the DSM, the diagnostic manual, just before it was published, the then head of the National Institute of Mental Health, Thomas Insel, kind of delivered a broadside to psychiatry. And what he said was that as long as the research community takes the DSM to be a Bible, we'll never make progress. People think that everything has to match DSM criteria. But you know what? He said biology never read that book. So in around 2011, under his leadership, the National Institute of Mental Health launched what was called the Research Domain Criteria, RDoC for short. The reorientation of research from DSM categories to biology was its purpose, and using genetics and neuroscience, neuroimaging, so that scientists could define disorders by their causes, not their symptoms. And since when we started our research, well, let's sort of go back to the numbers first and look at the rates of bipolar disorder in the general population and how it sorts out in terms of children and adults. Epidemiological general population studies show that over 5 million adults in the United States suffer from bipolar disorder. There's at least 750,000 children and teens that onset with the condition during those ages. One of the things that we determined with our research is that 1/3 of that group have all of the symptoms of this particular subtype of the condition that has been the focus of our research for the last 15 years. The first steps, when we started out, we were looking for, at that time in psychiatry, and still, there is no diagnosis for child bipolar disorder in the DSM. So clinicians are left to, in a sense, use the adult criteria for bipolar disorder to be able to make the diagnosis in childhood. And children that have this condition don't present in that way. They have a very different form of presentation. So typically, they're not diagnosed, and they're often not diagnosed till after adolescence. There's also a bias in the field of child psychiatry that more of an indoctrination, I would say, where it's taught in fellowship programs that bipolar disorder really can't exist in childhood, and it's very rare in adolescence. So basically, we have no points of reference, or clinicians have no points of reference when looking to diagnose bipolar disorder. So when we first started out, we basically we were starting off from square one, and we knew at that point that we were not going to use criteria for childhood bipolar disorder because they didn't exist. So what we did was we designed a questionnaire that turned out to have 65 items that we put up on the JBRF website, and were able to collect over 5,000 clinical profiles of children that were thought to have bipolar disorder in the community, or were thought to have a high likelihood of developing the illness because a parent or the family was heavily loaded with the condition. What we found when we looked at this large group of symptoms, we did a variety of statistical analyses, including factor analyses, which essentially sorts out specific groups and clusters of symptoms, looking for some kind of homogeneous grouping. And what we found was that there was a very, very specific group of symptoms that we were able to sort out using a dimension that we called fear of harm, that in a group of sibling pairs was a heritable phenomenon. So it was a group of symptoms that essentially was inherited, and we used that essentially to establish an entity that we called fear of harm. And this basically shows you the comparison between an individual who had bipolar disorder, who had fear of harm, and their sibling who also had fear of harm, and compared to two other non-biologically related siblings that were age and sex matched. So this was for us an indication that we had a particular subtype of juvenile bipolar disorder that was homogeneous and that had a heritable that was heritable. When we look the dimensions of this particular phenomena, this subtype, are listed up on the right here. And these were basically the terms that we used to describe the specific symptoms, most of which came from different categories of diagnosis in the diagnostic manual. So when we had developed the child bipolar questionnaire, we basically drew from maybe about 6 or 7 different categories that were already in the diagnostic manual. So the overlap with different conditions in the DSM essentially demonstrated to us that the boundaries that have been established in this nomenclature really are very permeable and are not necessarily, and are to some degree pretty arbitrary. So we went on to then look at a much larger sample of 1,700 cases, and we looked to see what was the incidence of fear of harm in this larger group of children and adolescents that had been diagnosed with bipolar disorder. What we found is that of this group, they separated into 3 different categories. There were individuals that had very high fear of harm, and that meant that they had every symptom of these different dimensions on the right. There was some that had virtually none, and there were some that had many, but not 100%. So this is essentially the way in this population fear of harm separated out, and this is what you would expect with a genetically inherited trait. One of the things that now you have to remember that when we were looking basically at clinical profiles that were provided, we weren't actually seeing live patients at this point after, when we did these analyses. When we started seeing people that were diagnosed, that we could literally diagnose with all of these symptoms, what appeared was a unusual phenomena that at the time made very little sense to us. But most of these kids had a thermoregulatory problem. They would overheat in neutral ambient temperatures. They would particularly overheat when they would lie down at night and before sleep. And they also had a significant tolerance for the cold. So they could go outside in winter with t-shirts on, and that wouldn't bother them. So what was surprising is this was a universal phenomena that would happen with all of these children that we saw. So what we were essentially wondered whether this particular phenomena, this thermoregulatory deficit, could be in some way a key to understanding the underlying biology of the condition. The research that we've done, since we asked that question has basically led us to an understanding that the answer to the question is yes. At the time, we really did not know what this meant to have this kind of problem with being able to thermoregulate. It wasn't clear whether these kids had a problem with dissipating heat from their body, whether they would generate too much heat during the day. What we learned from the literature, the chronobiology literature, was that temperature was an incredibly important phenomenon in terms of all sorts of processes that go on in the brain, and particularly in terms of the 24-hour rhythm of sleep. So one of the factors that these children have, one of the common symptoms that they have were sleep arousal disorders. They had trouble going to sleep, they had trouble getting up in the morning, they had sleep inertia, and they also had what are called arousal disorders that would occur in the transition between REM and non-REM sleep. Those specific symptoms include, they were basically REM sleep-related problems, parasomnias, night terrors, nightmares, and hypnagogic hallucinations. These kids typically have, at a very early age, very, very profound and vivid nightmares that are recurrent and that would go on for sometimes up to 3 years and often even up into adolescence. And this phenomena, as they would describe it, was traumatizing. I mean, imagine being a young child, waking up, or being, during REM sleep when your body is paralyzed, experiencing these very vivid, horrific dreams. So what we believe happens is they are essentially being exposed to trauma over and over and over again at a very early age. And so they are essentially auto-traumatized. And this phenomena that's based on a thermoregulatory deficit essentially leads to a whole developmental panoply of symptoms that develop secondarily. So, it's hard to imagine. It's very hard for parents, particularly when I try to explain to them how a problem with regulating temperature could possibly have any effect on and produce all of these sleep problems and the behavioral problems that emerge. And this slide, I think, really kind of captures how important fluctuations in core temperature are to human beings. I don't have a pointer, but you can see at the bottom of the first image that sawtooth wave. That is essentially a regular 90-minute rhythm that's generated, and that is essentially temperature variations that are going on as we go into sleep, and those larger bars are basically transitions between REM and non-REM sleep. The upper darker part of the image, these are changes with their brain waves, and they are also strongly correlated with temperature changes that are going on in the brain. So it has a powerful effect, and it does essentially produce significant symptoms. When we realized that this might really be at the core of the condition, we did actually a study at Cornell with Marge Moline at the sleep center there, and we looked basically at sleep-wake records of these kids, measuring their peripheral and core body temperature. So let me explain here. The red line that you see is distal temperature. Basically, that's shell, core, surface temperature, and proximal is the core temperature. And you can see the differences in both of these cases. The first case is one of a neurotypical child that does not have fear of harm. The second is of a child that does have fear of harm. When these points of inflection occur at the beginning of sleep, this is when you enter into sleep. So they have to be essentially coming together to be able to go to sleep, and in the morning they have to come together again, basically in this inflection point, to be able to wake up. And you can see that both at sleep initiation and sleep offset, the individual with fear of harm does not have this necessary point of inflection at both ends of the spectrum at the onset of sleep and offset. And so this basically, we consider this thermoregulatory deficit, that this to be the marker and to be the reason why these children have significant sleep disruptions, both getting to sleep and getting up in the morning from a very, very early age. So this child, there was around 2009, there was a patient of mine. We had just sort of gotten to the point where we had identified this phenotype. We had identified the symptoms that we talked about before, and this 8-year-old young girl had all of the symptoms to beat the band. She had severe sleep disorders. She had nightmares, night terrors. She had severe separation anxiety. She was sort of Velcroed to her mother's hip, and also was hallucinating during the day. She was on maybe 6 or 7 different psychotropic medications, and she was unstable. There was no way of stabilizing her. She was just very, very difficult. At that point, we had the two cardinal features of this syndrome, fear of harm, really we had realized was fear sensitization from the auto-traumatization that had occurred with the recurrent nightmares, and this thermoregulatory deficit. So these were the two cardinal features of the condition, and we decided that we would look and search in the literature to see if we could find some medication that might possibly be available that would affect both those phenomena. And we stumbled on ketamine. The animal studies showed that ketamine had a direct effect on reducing fear sensitization in animals, and it also dose-dependently lowered body temperature. So it seemed like it would be a real possibility for treatment. At that time, in 2009, ketamine was not even being discussed as a possible treatment for psychiatry. It essentially has been primarily used over the last 35 years as an anesthetic. It's the most commonly used anesthetic in the world, basically, but never really was it considered something that you could prescribe. And there were no indications for using ketamine at that time for psychiatric conditions, and certainly not in 8-year-old children. But Ketamine is commonly used for dental extractions in children by dentists. And we told the mother what we had in mind, and she was interested, convinced her dentist, who was going to be doing a dental procedure on her child, to give IV ketamine to the child. And within an hour after receiving the IV ketamine, basically all of her symptoms were abolished, and they essentially left for 2 weeks, at which point she started overheating again. The sleep problems came back, and all of the psychiatric symptoms that she had returned. So obviously I couldn't tell the mother that we were not going to be continuing with the ketamine. So we found a way, administering it intranasally, that we could get it into the brain. And she was the first patient that began with ketamine. She's now, she's about, 17 years old now? 16, 17 years old. She's about to go to college. She's living in Westport, and she's been symptom-free basically since she's been taking ketamine since we first started. This is, you can see the before and after ketamine in this child. It was this one case, but I can tell you we've treated about 180 children at this point, in adolescents and some adults. And the responses have been, I don't use the word lightly, but they've been pretty transformational. And they've made huge differences in the lives of children and in their families for this particular condition. And this is what we focused on. So, I'm not gonna go through this, but you can just see, if you look through a few of these items, how the things dramatically changed from pre and post ketamine treatment. So, you know, it's been in the news quite a lot over the last few years, because it's now being reported as effective, and has been shown to be effective to treat so-called treatment-resistant depression, or whatever that is. We would be very interested in looking at the sample of individual cases that are adults typically that are receiving IV ketamine and that have a very good response, because we suspect that a lot of those adults that are responding to IV ketamine basically have this syndrome. That's obviously a speculation, but it would not surprise me. Now, we've kind of gone beyond that, at least in terms of being able to try to understand the underlying biology. I mean, that was part of the mission of the JBRF, to identify a homogeneous subtype of early onset bipolar disorder that had a biological marker, and a treatment that would work effectively for kids with the syndrome. One of the things that has been studied in various laboratories now, they're looking at what's the underlying molecular genetic action of ketamine. How does ketamine actually work at that level? Ronald Dumont from Yale did some of the original studies showing that ketamine had a specific effect on a gene, which is called BDNF, brain-derived neural growth factor, which turns out to have an important role in thermoregulation, sleep, mood disorders, fear, and aggression. All of these things are affected by BDNF. The thermoregulation, BDNF turns out in animal studies to be extremely effective. It regulates the thermal set point developmentally at a very early age. So how you as an individual thermoregulate depends on the presence, let's put it that way, at a certain developmental point, like an imprinting point of the appearance of BDNF. And it is extremely important in both the consolidation and the extinction of fear memory. So it's a really good candidate since we know ketamine induces BDNF as a way of explaining, what's going on at a molecular level with ketamine in this condition. Just briefly, this is a slide basically that shows one of ketamine's effect on BDNF in the brain, actually, in animal studies. So, and this is also from Ronald Dumont's work at Yale. BDNF basically in neurons essentially will rapidly, within hours, increase the essentially the synaptic connections between neurons. And that is a marker for being able to essentially create new learning and memories. So this is something that may explain why it may have a sustaining effect on developing new behaviors, in these individuals that are taking ketamine. Because we know that this condition is not going to be and is not currently being diagnosed except for a handful of clinicians around the country until it becomes part of the DSM. These are criteria that we've essentially proposed that fit the DSM model. This is not the way we would want to describe it, but this is the way it would appear in the DSM. And what we would require is that most of the symptoms, all of these categories, A through F, would have to be present to make the diagnosis, and that it is common that there's a family history of recurrent mood disorders and or alcoholism, as well as other bipolar spectrum disorders in families that with kids that have this condition. As you can see, some of the behaviors are they're extreme. The early, because of the auto-traumatization, some of the earlier symptoms that are related to this fear sensitization, which we call fear of harm, there's this strong fear of intruders, there's a fear of a threatening presence that's going to hurt you. These children easily misperceive or experience neutral stimuli as threatening. They often have obsessive bedtime rituals. They're afraid to go to sleep because of the nightmares. They have fear of the dark, separation anxiety, contamination fears. They're very hypervigilant and they have reactive aggression. So they can be very aggressive when they feel like they're being thwarted in any way. So this makes this group of children some of the most difficult to treat. The ones that many of them end up, unfortunately, because they're not diagnosed in the juvenile justice system. We estimate that probably a third of kids that are in the juvenile justice system have fear of harm, and unfortunately, the conditions that they end up being diagnosed with, which is like an alphabet soup of diagnoses from the DSM, essentially are treated with medications that make these kids worse. So we're hoping that we know that the foundation faces a formidable challenge. We're on the one side, fear of harm has an easily detectable marker, very specific symptoms. We can diagnose this condition as early as 6 years old. Ketamine treatment is safe, it's effective, and inexpensive. On the other hand, fear of harm is not in the DSM. The FDA is very risk averse when it comes to pediatric psychiatric studies. And Big Pharma has a vested interest in promoting its proprietary drugs and maintaining the DSM, essentially the categories the way they are. And also ketamine is used to have abuse potential as a street drug. So we're hoping that we can tip the balance with your help and with the help of others to get this condition better known and to move it into the mainstream of clinical psychiatry so that these children and their families can get some relief. Okay, I think I'm going to end.